Good morning, everybody. Thank you for having me. We've had some great talks. I hope I can match the quality. But thank you to the organizers. Thank you to Cardin Jennings for helping us put this together. So I'll be talking about the recently updated, kind of renewed, refreshed AUA 2024 prostate cancer, advanced prostate cancer guidelines. Just one thing that they wanted to note when they put this out was that it's less of an update and more of a recreation, because in the time that it was last done was 2013, and there's been a preponderance of results from a vast number of trials, and they just wanted to make, they wanted to isolate and kind of put all that stuff together and have a new consensus document that kind of overhauled the guidelines. Oh, I went back. Okay, here we go. So just to start, so this portion of it was treatment decision making at the time of suspected biochemical recurrence after primary radical prostatectomy, and they were talking about the effectiveness of salvage radiation therapy based on PSA levels, and they noted that salvage radiation therapy is more effective when administered at lower PSA levels after radical prostatectomy, and that has to do we'll talk about that a little bit later, but when we look at PSAs and rising PSAs and with the incorporation of PSMA PET, the entry for most of the trials was around 0.2 to 0.5, but they found that, at least from the information that they were reviewing, was that when they entered with lower PSA levels, the effectiveness was better. The moderate recommendation here being that salvage radiation therapy should be provided when PSA levels are less than or equal to 0.5. I know that some people wait for that 0.5, others will wait for 0.1, 0.2 to refer to a radiation oncologist. And then they're saying that, at least with a grade C conditional recommendation, patients at a high risk of clinical progression, salvage radiation therapy may be offered even when PSA levels are less than 0.2 nanograms per milliliter. And they're enlisted there are the high risk of clinical progression, which you can kind of think through here. The higher Gleason grade groups, 4 through 5, advanced pathologic stage, so T3B, T4, node positive disease, and then aggressive or fast PSA doubling times. And then additionally, surgical margin status is taken into account. But these are all patients that are high risk of progression. Consider sending them to radiation for treatment at an earlier or lower PSA. And so when you're making this decision, they wanted to comment on the fact that you have to have a discussion with the patient regarding the risks of salvage radiation after radical prostatectomy. And so patients should be informed that salvage radiation therapy after radical prostatectomy carries inherent risk to urinary control, erectile function, and bowel function. So the SWOG 8794 trial was a randomized trial comparing observation to adjuvant RT after radical prostatectomy, and so radiation therapy was associated with worse short-term outcomes, but long-term quality of life at 5 years there was no difference between bowel or sexual function. And although radiation therapy had worse urinary symptoms, they did have better overall quality of life, so those that got treatment after radical prostatectomy. And then they mention here the use of prognostic factors is a grade B moderate recommendation. So they should use prognostic factors, like we kind of mentioned in the last slide, the use of PSA doubling time, Gleason grade group, et cetera. And I think that PSA doubling time, they mentioned a study that when they looked at patients that had a much faster PSA doubling time, less than 6 months, they had a hazard ratio of 4.9 for progressing to disease, or excuse me, for death from prostate cancer. And then as you got further out with the doubling times, they mentioned greater than 10 years, the hazard ratio was 1.5. So there's a correlation with that PSA doubling time as well. Okay, and then they wanted to comment on the use of ultrasensitive PSA testing. Now, it's an expert opinion, and they said the clinicians may obtain ultrasensitive PSA following radical prostatectomy in patients at high risk of recurrence or who are being considered for salvage radiation therapy. And that ties back again previously. They're trying to hammer home the point that we should be more aggressive in terms of monitoring these patients that have higher risks of progression. And that's where, and then if when we come back to this confirmation of rising PSA trend, another expert opinion, patients who do not meet the AUA definition of biochemical recurrence, which we know is greater than or equal to 0.2, but have a detectable ultrasensitive PSA, you should at least get a trend that it's rising before acting forward in terms of referring them to radiation therapy. Okay. And then I pulled out a quote from the guidelines where it said, PET radio tracers have changed the landscape for imaging biochemically recurrent prostate cancer, which is, I think, what Dr. Thomas kind of informed us all about. It's a very powerful tool that we now have in our toolbox. Listed in they listed this information here in the table on the left on the varying levels of PSMA, or I guess these PET radio tracer detections at different PSA levels. And for the most part, it gets better in terms of detection rate. As you get to the higher numbers, you're getting more to the whole numbers, 1 to 2, greater than 2. And just to highlight there at the bottom, because we will recommend some patients can get PSMA or PET scans less at the 0.2 level, but the detection rate is still not the best at 40%. That was, of course, that was a meta-analysis that the guideline committee looked at to develop that kind of information there. The other thing, of course, you get over 5, and then you have really good detectionability with the PSMA PET. So I don't think that this should, at least going with the guidelines here, is the conditional recommendation of grade C. In patients with biochemical recurrence after local therapy, clinicians may obtain a prostate-specific membrane antigen or PSMA PET scan in lieu of conventional imaging. And they were careful to just mention biochemical recurrence. So the threshold that they're defining, really they're hanging on to, is that 0.2. So I think if someone has a biochemical recurrence, I think it's okay to forego the table and get the PSMA PET scan just based on this recommendation. Because if let's say you get into that gray area of what if there's nothing on the PET scan, well then you can consider the conventional imaging to augment that. And then in patients, and then the next one, the next generation molecular PET imaging, in patients with BCR following radical prostatectomy where salvage radiation is being considered, you should perform the next generation molecular PET imaging. And then the incorporation of PET CT findings in radiation planning. This is a moderate recommendation, grade C, for patients with BCR after radical prostatectomy with PET CT positive pelvic nodal disease. Clinicians should incorporate treatment of these positive findings in the radiation plan. So they're encouraging these studies to really just be used and included in the development of our either adjuvant versus salvage treatment plans. Okay, and then just moving forward. So again, with respect to treatment decision, so the use of pelvic MRI, clinicians may obtain a pelvic MRI in addition to PET CT for the evaluation of local recurrence in patients with BCR, and then salvage prostate bed radiation therapy with a negative PET CT. So clinicians should not withhold salvage prostate bed radiation therapy in patients with biochemical recurrence following radical prostatectomy, even if the PET scan is negative. So I think that's a group that most of us may encounter if we have patients with high-risk pathology, let's say a positive margin, and they have biochemical recurrence. I think most of us understand that we should, in those cases, proceed with salvage radiation, and they are encouraging that, at least with an expert opinion. Okay, and we'll move to the next one. Okay, so treatment delivery for non-metastatic biochemical recurrence after primary radical prostatectomy. So androgen deprivation therapy with salvage radiation therapy, so a grade B moderate recommendation. So clinicians should offer ADT in addition to salvage radiation therapy for patients with biochemical recurrence following radical prostatectomy who exhibit any high-risk features. Again, that's waiting again for biochemical recurrence after an RP. And I think that's where a lot of there's new development happening in much of the kind of the genomic testing and the more advanced testing to see if patients would benefit from ADT. But overall, they are recommending it at a grade B to proceed with ADT in that setting. And then radiation alone for low-risk patients. For patients with BCR following radical prostatectomy who do not have any high-risk features, clinicians may offer radiation therapy alone. So they're trying to stratify out those ADT candidates that won't benefit so that they don't have to have the side effects. And then again, the discussion of the treatment side effects when it comes to ADT as it may apply. And they're just encouraging the clinicians to have those discussions with the patient. Okay, and then let's see. Yeah, okay. So treatment delivery for non-metastatic biochemical recurrence after primary RP. Again, we're continuing. So post-operative node-positive disease, and this is a clinical principle. Patients with pathologic node-positive disease treated with post-operative radiation therapy, clinicians should include ADT in the treatment regimen rather than treating with radiation alone because of the potential for more systemic kind of widespread disease. And then the minimum duration of ADT, they are saying that 4 to 6 months should be the minimum for ADT to augment the salvage radiation therapy. And then they do mention that extending ADT is important for those that have high-risk disease, and specifically going out to the 18 to 24 months. And again, this is for biochemically recurrent patients, not primary treatment, but this does somewhat align with our primary treatment patients as well. We do understand that ADT improves the effect of radiation. And then continuing on, so they talked about expanded radiation fields. This is a grade B recommendation. So in patients with biochemical recurrence following radical prostatectomy undergoing radiation therapy with ADT, clinicians may use an expanded radiation field that include the regional lymph nodes. And again, they encourage the clinician to talk about the side effects of the expanded radiation field. And a lot of this came from looking at the recent trials, the RTOG 3506 and the ECOG Akron Indicate studies were kind of mined from for this information. And then intensified androgen receptor suppression, a clinical principle. So for patients with node-negative disease, clinicians should recommend the use of intensified androgen receptor suppression with salvage radiation therapy only within a clinical trial setting. So that was coming from the Stampede trial, and even though it did support the use of abiraterone with ADT for high-risk non-metastatic prostate cancer, they recommended that the intensified androgen receptor suppression combined with salvage RT should be restricted to clinical trials due to that being an area of discovery that's still ongoing. Okay, all right, and then so evaluation and management of suspected non-metastatic recurrence after RT. So they're recommending in regards to prostate biopsy for local recurrence. So this is a clinical principle. So they're saying that patients with biochemical recurrence following primary radiation therapy or ablative therapy who have no evidence of metastatic disease, they should get a prostate biopsy, and that can be done with the guidance of MRI infusion for a more higher quality biopsy. And then they're talking about options for local salvage therapy, a grade C, so patients with biopsy documented prostate cancer recurrence after primary radiation therapy, they can consider options such as salvage radical prostatectomy, cryoablation, high-intensity focused ultrasound or HIFU, or re-irradiation. Again, the important aspect here is that it's a shared decision-making approach with the patient and the clinician. But those are all options for the treatment after primary RT. And then an expert opinion for whole gland treatment for salvage therapy. Clinicians should offer salvage radical prostatectomy or salvage radiation therapy. And this recommendation is based on the understanding that the multifocal nature of prostate cancer may necessitate comprehensive treatment to effectively manage recurrence. So they're giving an avenue for patients to undergo focal treatment, focal salvage therapy, but also there is the strong recommendation that as we understand the disease process of prostate cancer, really comprehensive treatment of the gland, of the organ, is also recommended by the panel. So they wanted to give two kind of roads that can be taken. Again, with the importance being that shared decision-making needs to be employed here. Okay, so then management of pelvic nodal recurrence after radical prostatectomy. So patients with pelvic nodal recurrence following primary radical prostatectomy should offer androgen deprivation therapy plus salvage radiation therapy to both the prostate bed and the lymph nodes. It's a little repetitive from earlier, but they wanted to just hammer home the issues of pelvic nodal recurrences. And then after radiation therapy, they are recommending that salvage pelvic nodal radiation therapy can be considered, and then also combined with ADT. And then with respect to salvage pelvic lymphadenectomy, that's a grade C conditional recommendation. So clinicians may offer salvage pelvic lymphadenectomy for patients with evidence of pelvic lymph node recurrence after radical prostatectomy or radiation therapy. But again, let's say you have one isolated oligometastatic lesion, it's hard to predict what more may be there, but it has to do, you have to counsel the patient that this may not be curative, but at times it is an attempt to cure. And again, they want to just hammer home, and they repeat that a lot in the document about the potential benefits versus the risks of the disease, of the intervention, excuse me. Okay, and then management for molecular imaging metastatic recurrence. So stereotactic ablative radiotherapy for oligo recurrence. So patients with evidence of regional or metastatic oligo recurrence following primary therapy, either surgery or radiation, clinicians may perform the ablative radiotherapy as a form of metastasis-directed therapy. But again, consider the risks of the toxicity versus the potential benefits. And then omission of salvage radiation therapy for non-regional disease. So this is so regarding that, patients with biochemical recurrence who have non-regional disease detected on PET-CT but no visible disease on conventional imaging, clinicians may omit salvage radiation therapy to the prostate bed. So it can be just completely directed metastasis-driven therapy. So the conclusion that they made in the guidelines was that there exists a need in multiple realms for more information, because we're still kind of in that early discovery phase when it comes to either androgen synthesis inhibitors or radiation therapy, either stereotactic or how do we include then focal therapy. But we are moving forward as a field in terms of our management of this disease with the many different kind of things that we have available to us. So I think it's an exciting time as things get more and more evolved, and our understanding of the disease process evolves as well. And I'm excited for the future to see what comes of that. But that's all I have for this portion. This kind of reviewed the 2024 prostate cancer kind of new, I would say not updated, but kind of recreated or revisioned guidelines. So thank you so much.